Right. Welcome everyone to Women Wellbeing Lecture Series hosted by Resiliency and Wellbeing Center. This series is made possible by generous support of Dr. Rosemary Bose Endowment Fund that supports women's health and well-being. And it's my pleasure today to welcome our wonderful presenter, Dr. Courtney Jackson. Dr. Jackson earned her doctorate in Naturopathic Medicine from the National University of Natural Medicine and holds a Bachelor's of Science in Resource Ecology Management from the University of Michigan. In 2013, she was a co-founding physician of the Food as Medicine Institute in Portland, Oregon, where she developed the Food as Medicine Every Day or FAME program, a 12-week experiential cooking and nutrition series. She's an experienced writer who has worked with academic and healthcare organizations to develop evidence-based nutrition content. She just published a second edition of her book, Food as Medicine Every Day. Reclaim Your Health with Whole Foods, along with Dr. Julie Briley, which is used as a nutrition and academic resource for the FAME series. Dr. Jackson currently practices at Women's Health Clinic in Portland, where her clinical focus includes an integrative approach to cardiometabolic health. Dr. Jackson, it's our pleasure to have you, and please take the stage.
Thank you so much. Thanks for that introduction. I've got my slide deck and my notes, so we'll move along here. So hi everyone, hi listeners. It's 9 o'clock here where I am. I believe it's lunchtime where you're at. So hopefully you're getting time to eat some good food. It's a pleasure to be here speaking about women's cardiometabolic health during the month of February, as this is American Heart Month. And today I'm going to be speaking about my clinical experience managing cardiovascular disease risk at an integrative OBGYN clinic in Portland, Oregon. And I have a really unique position working with my OBGYN colleagues as a naturopathic doctor. And I would love to see this type of collaboration increase as patients are often looking for an integrative approach to their healthcare. And I want to recognize Dr. Laura Williams and her team for having a vision of this type of collaborative care for our patients. And yes, that is an ND and not an MD behind my name. And that is important in the collaborative work that I do in my clinic because I have extensive training as a naturopathic doctor in using clinical nutrition and lifestyle medicine counseling as a foundational piece of my treatment plans. And also, there's a lot of overlap between a woman's OBGYN history and her risk for developing heart disease. And additionally, as you heard, I'm an author and recently published a second edition of a book called Food is Medicine Every Day, which is a nutrition resource that's used both inside and outside academic and healthcare settings. So the first edition of the book was published about 10 years ago when I was working for NUNM and developing their Food is Medicine Institute and teaching their FAME series. So I hope you all can leave this talk today knowing that heart disease is a highly modifiable chronic disease with up to 80 to 90% risk reduction through lifestyle measures like physical activity, healthy nutrition, healthy weight management, and not smoking. But the American Heart Association estimates that only about 5% of individuals follow all of these lifestyle factors. So the challenge to the healthcare community is to more consistently incorporate this information into the daily practice of medicine. And when we're discussing chronic disease and modifiable risk factors, we need to acknowledge that there are upstream factors that shape an individual's and a family's and a community's behaviors and lifestyle factors that lead to heart disease. And these are social drivers of health, and they include economic stability, education, food, neighborhood and physical environment, community and social context, and the healthcare system. So it is important to empower individuals with accurate and credible information to reduce their healthcare risks, and also a multi-level and team-based approach, including interventions that improve income, environment, healthcare access, and education, will offer a more sustainable strategy to reduce the overall burden of heart disease. So let's review the whys of why prioritizing heart health and women's healthcare is so important. Heart disease is the #1 cause of death for women, and yet only 44% of women recognize that this is their greatest health threat. So what do you think most women are concerned about? That would be breast cancer. Heart disease starts in youth, with over 45% of females in their 20s already having some form of heart disease. And pregnancy can serve as a stress test to a woman's cardiovascular system. And cardiovascular disease is the #1 cause of death in new moms, with Black women having the highest rates of maternal mortality. And this disparity is thought to be due to social drivers of health. Reviewing a woman's obstetric history matters because high blood pressure in pregnancy, preeclampsia, and gestational diabetes all increase a woman's risk of developing heart disease. The menopausal transition is a key stage to pay attention to because cardiovascular risk factors can accelerate due to declining estrogen. Estradiol promotes vessel flexibility and healthy blood flow in the coronary arteries, exerting a cardioprotective effect premenopausally. This includes promoting a healthy lipid profile, and this protection is diminished. And severe vasomotor symptoms are independently associated with heart disease risk. And menopause is also a period of increased metabolic change, including weight gain and insulin resistance, and commonly prolonged sleep disruption. And again, we know that most cardiac and stroke events are highly preventable. Hypertension continues to be one of the most undertreated conditions in women's healthcare, especially in Black women. And again, the social drivers of health are a key reason. And this next statement on the American Heart Association website actually really caught my attention, that women are less likely to receive CPR because of fear of inappropriate touching or injuring the victim. And finally, women can continue to be underrepresented in the STEM fields and in research, and only about 40% of participants in clinical cardiovascular trials are women. And women from non-white racial and ethnic backgrounds are even further underrepresented. So let's define cardiovascular disease. It's defined by the presence of disease in the heart or the vascular system. Forms of heart disease include coronary heart disease, stroke, atherosclerosis, heart failure, peripheral artery disease, dysrhythmia, heart valve disease, and cardiomyopathy. And it's disease driven by inflammation. And if you recall from anatomy classes, the endothelium needs to maintain a balance in the coronary artery system for proper function, but it can become injured and dysfunctional under the conditions of smoking, high cholesterol, high blood pressure, diabetes, and other chronic inflammatory states. And this can lead to the recruitment of oxidized LDL cholesterol and immune cells that then lead to plaque progression. And this results in a decades-long process of chronic arterial inflammation that can manifest as atherosclerosis and coronary artery disease. So screening for cardiovascular disease is included in the primary care setting. And in my case, I receive referrals from my colleagues for patients who already have an identified risk factor. So I review clinical symptoms related to heart disease, including classic symptoms like chest pain or shortness of breath. But in the case of women, it's important to ask about symptoms like fatigue, depression, and sleep disruption. Pay attention to both the patient and their family history regarding hypertension, hyperglycemia, diabetes, smoking, and be sure to ask clearly about a family history of premature cardiovascular disease, which is defined as having a first-degree relative who has had a heart attack or stroke or cardiovascular death before age 55 for males or before age 65 for females. And the risk of a woman developing premature coronary heart disease increases with a number of her family members affected. Screening labs typically include a cholesterol panel, a fasting glucose, and a hemoglobin A1C, and a thyroid test. And a high-sensitivity C-reactive protein test can assess a woman's inflammation level. Apolipoprotein B or ApoB provides a more sensitive marker of risk than LDL cholesterol alone, although ApoB has not yet entered into the recommended standard of lipid panel testing yet for all patients. The physical exam will include a BMI calculation and checking blood pressure. And then ideally, we should be checking waist circumference with women with a healthy goal under 35 inches or 88 centimeters, due to the significant amount of research showing increased risk associated with central adiposity and its relationship to increased inflammation. But it's not yet a universally common clinical measurement, and it can be a sensitive measurement to obtain. And I'm personally working on introducing and discussing this measurement more frequently with patients. And occasionally it's necessary to consider additional diagnostic tests, such as an EKG to assess abnormal rhythm, or an echocardiogram to assess heart structure and blood flow. The coronary artery calcium score, which measures calcified plaque, is an important image that helps differentiate lipid-lowering treatment options, particularly for women at borderline or intermediate risk for cardiovascular disease, which can be determined by using one of the CVD risk calculators that I will discuss later, as well as using good clinical judgment. And it's important to differentiate with women their non-modifiable risk factors from those that are modifiable. So the non-modifiable risk factors include increasing age, family history, both early or late menarche, premature menopause, and race and ethnicity. So there's a lot of overlap between a woman's gynecological and obstetric history and her risk for cardiovascular disease. And these include having a history of preeclampsia, gestational diabetes, or preterm delivery. So preeclampsia significantly increases long-term cardiovascular disease risk, including hypertension, ischemic heart disease, and stroke, which is thought to be due to the shared mechanisms of endothelial dysfunction and inflammation. Women with a history of gestational diabetes have a 10-fold increased risk of developing diabetes, and this risk increases linearly throughout her lifetime. Premature menopause, which occurs before age 40, and early menopause, which occurs before age 45, are both strongly associated. Polycystic ovarian syndrome and its association with insulin resistance, reviewing the types of birth control or hormone replacement therapy used in the past or currently, including oral estrogens, the presence of autoimmune disease, which can contribute to chronic inflammation, and the presence of depression, which is independently predictive of heart disease in women. So it's really important to screen for this and offer treatment when indicated. And then there's a condition called broken heart syndrome, which mainly affects postmenopausal women and is typically triggered by extreme physical or emotional events. And here are the modifiable risk factors that we will spend the rest of our time reviewing. And these include, of course, smoking. Female smokers have a higher risk than male smokers, blood pressure, fasting glucose, cholesterol, BMI, physical activity, and diet. So we know just spending 1 to 3 minutes counseling in the office visit on smoking cessation is time well spent. So I have some resources for you to review, and I have included, well, it's also important to emphasize that the FDA-approved medications along with behavioral counseling leads to improved smoking cessation outcomes. Blood pressure continues to be an undertreated condition in women's healthcare. So these are the updated 2025 American College of Cardiology and American Heart Association Joint Committee's definition of hypertension. And there are some changes in terms of recommended management. The following lifestyle recommendations should be reviewed with any woman who has elevated blood pressure. That's 130/80 and above, or hypertension, which is 140 or 90 and above. And that, of course, includes addressing healthy weight, following a heart-healthy dietary pattern, with the Mediterranean and the DASH program, dietary approach to stop hypertension, being the most resourced and referenced. Reducing sodium intake and increasing dietary potassium, managing or adopting a physical activity program, managing stress, and reducing or eliminating all alcohol. For a woman with average blood pressure measuring within stage 2, or for women with an average blood pressure in stage 1, who also have clinical cardiovascular disease or history of stroke, diabetes, or kidney disease, or if she has an increased 10-year predicted cardiovascular risk, initiation of blood pressure lowering medication in addition to lifestyle intervention should be discussed. And combination drug therapy is now recommended for stage 2. And we have a couple different CVD risk calculators to consider. These risk calculators help to stratify patients with elevated lipids or blood pressure so that different lipid lowering or hypertensive therapies can be considered in addition to those lifestyle measures that we reviewed. And I'm most familiar using the American College of Cardiology calculator. However, in 2025, the American Heart Association put out their Prevent calculator, which now includes zip code in place of race and ethnicity, as well as additional kidney function parameters and diabetes risk assessment. So these risk calculators help guide clinical decision making for treating hyperlipidemia or hypertension, and I'll often complete the risk calculations together with the patient. Recommending and teaching how to do home blood pressure monitoring is important for accurately determining if someone has hypertension versus white coat hypertension, or if the blood pressure measurement was just improperly collected in the office. And this also empowers women to take ownership of their own blood pressure management. Handouts and websites can be helpful. Remind women that upper arm blood pressure monitors are preferred over wrist monitors, and also that the cuff must be appropriately sized. So data shows that about 38% of women with hypertension require a cuff size different from standard adult size cuffs. I typically have her record twice daily measurements for 1 to 2 weeks to be reviewed at a follow-up visit. And like blood pressure, managing blood sugar is highly modifiable risk factor for cardiovascular disease. So pre-diabetes affects more than 1 in 3 females in the United States, compared to about 1 in 10 for diabetes. And this can be determined by a lab test of fasting glucose with 2 elevated readings between 100 and 125 milligrams per deciliter, or A1C of 5.7% or higher. And women have an increased risk of prediabetes with a history of gestational diabetes, PCOS, being overweight or obese, or having a family history of diabetes. We know lifestyle modifications are very successful in managing prediabetes and can even outperform a glucose-lowering medication like metformin. And in some cases, and depending on other risk factors beyond prediabetes, I might also consider including nutrient therapy like myo-inositol, especially if she has PCOS, or herbal therapies like berberine to support glucose lowering in addition to those lifestyle factors. And we may also decide to do a 15-day trial using a continuous glucose monitor so that we can better understand how her blood sugar is impacted by different lifestyle habits, from diet to exercise, stress, and sleep. And this can be a very empowering intervention for her to make connections and inspire behavior changes. I take time to review all the parameters of the lipid test with my patients because they each confer different risks or protection for heart disease, and they each have different lifestyle factors that can influence them. So reducing elevated levels of LDL and non-HDL cholesterol is highly effective at reducing heart disease risk. And I will order a follow-up lipoprotein A test, which is a highly genetically influenced evaluation. If a patient has a significantly elevated LDL cholesterol, certainly above 190 milligrams per deciliter, as this may be related to familial hypercholesterolemia, or I will initially include an LPA test if they have a family history of premature cardiovascular disease. And I've been ordering a high sensitivity CRP lab test regularly since reviewing publications from the Women's Health Study showing women with a baseline CRPHS greater than 3 milligrams per liter had a 70% higher risk of major adverse cardiovascular events compared to those with a HSCRP less than 1. And so this supports the role of chronic inflammation as a driving force of heart disease. And it can help guide treatment decisions that are anti-inflammatory, certainly from a nutrition perspective. I receive a lot of referrals from my colleagues for patients who are interested in discussing weight loss as a healthcare goal. And it's really important for me to navigate this topic with respect and honesty and a philosophy of partnership with my patients. So we know BMI is not a perfect measurement, but it can be a helpful piece of the metabolic puzzle. And for women who have an elevated BMI and who are interested in creating a weight loss plan, this will include an assessment of where they are, if there's an imbalance in energy use from food and activity, as well as consideration of other hormone imbalances such as hypothyroidism, the menopausal transition, PCOS. And we review their medications that can contribute to weight gain, like certain SSRIs, those selective serotonin reuptake inhibitors, some psychiatric medications, corticosteroids. We review sleep habits and stress perception. And I let women know that 5% weight loss, when indicated, can have a significant impact on metabolic function, on blood pressure lowering, reducing the risk of progressing to type 2 diabetes. And this level of weight loss is achievable through dietary and lifestyle efforts. And when we determine that a weight loss goal of greater than 10%, certainly greater than 15%, is indicated, then we may discuss the role of FDA-approved weight loss medications in addition to lifestyle components. All right, so we're going to be moving into modifying dietary habits. So if you don't have training to confidently discuss nutrition, then partner up with a provider who does, because women have a lot of questions in this area, and they also have a lot of easy access to a lot of unreliable nutrition information. For cardiovascular health, I pull from nutrition recommendations based on the Mediterranean diet, the DASH diet, and more commonly for me, the Food as Medicine Everyday program. And all of these dietary patterns share similar themes on focusing on low processed, nutrient dense, and fiber rich foods, lean sources of protein, appropriate caloric intake for the individual, and limiting added sugar, unhealthy fat, and sodium. These are the guiding principles of the FAME program. And I'm pleased that this program was developed actually over 10 years ago, probably closer to 14 years ago. And these principles have maintained as foundational. So promote whole and minimally processed foods and beverages, include a diverse, primarily plant-based diet, include foods from healthy animals for people who choose to do so, promote anti-inflammatory food choices, recognize each individual has unique food needs, and care about food and its sources. So again, in this program, we have an opportunity to revisit these principles on a weekly basis. And also, if you recognize the man in the red jacket in the photo, if he looks familiar, that is Bob Moore. You might see his picture on your whole grains, and his wife, Charlie Moore. They're founders of Bob's Red Mill, a whole grain company based in Oregon. They've both since passed, but they were instrumental in supporting the Food as Medicine Everyday program. So the FAME program is offered through NUNM's Food as Medicine Institute, which has been offering 10 to 12-week hands-on nutrition and cooking series to our community since 2011. These courses are taught by naturopathic doctors, registered dietitians, and nutritionists. And I was involved in a small pilot study that was published in 2019 in the Journal of Alternative and Complementary Medicine that showed adults with prediabetes or at risk of prediabetes who participated in a FAME series. There was a shift toward healthier cardiometabolic lab values at the end of the program, as well as at 6 months and 12 months after the start of the program. And that included a lowered fasting glucose, lowered CRP, lowered total cholesterol, lower LDL and triglycerides. And during the pandemic, the FAME program moved to a virtual option as well. So the FAME series is based on its guiding principles as well as on the Latin word for diet, which I will try to pronounce, dieta, which means way of living. So the goal is to help people move toward a less processed diet that provides more nutrition and appropriate caloric intake, while also recognizing that over 70% of the US food supply is ultra processed. So we need to learn how to navigate that system to make the healthiest choices possible. So in my clinic, I get to spend time emphasizing the importance of nutrition with my patients by first taking a brief dietary intake, getting just a general assessment of their overall nutrient intake and learning about their individual habits or needs. And I do teach very basic nutrition language and physiology in the clinic so that women understand the why behind my clinical recommendations that may include increasing lean protein and fiber and shifting their dietary fat intake. And I also want to empower them with this type of language so that they can better understand food labels. So my patients hear all the time about focusing on protein, fat, and fiber when building a meal or when ordering out. We review the importance of protein intake for building lean muscle and for providing a source of slow energy is how I describe it, as opposed to quick energy from quick carbohydrates. And this is really important for women who are struggling with that late afternoon energy crash. Sometimes focusing on protein can really make a profound effect on their sustained energy throughout the day. It has a positive impact on satiety, so we can see a direct effect on cravings, and its role, it has a role in increasing the thermogenic effect of a meal, which of course can support metabolism. And I spend a lot of time individualizing protein intake, being thoughtful about that. And my recommendations were generally above the previous RDA of 0.8 grams of protein per kilogram of body weight. And so for a 180-pound woman, that recommendation would have amounted to about 65 grams of protein a day. But the most recent dietary guidelines for Americans do recommend an increased amount of daily protein, ranging from 1.2 to 1.6 grams of protein per kilogram of body weight. So for that same 180-pound female, this equates to 98 to 130 grams of protein per day. So that's quite a difference. So what do I take into account when individualizing protein recommendations? Age, for one. So women over 50 have an increased need of daily protein intake based on a decreased ability to absorb protein as efficiently as women age, as well as to compensate for the loss of lean muscle mass associated with aging and the menopausal transition. So I may be recommending 1 gram up to 1.5 grams of protein per kilogram of body weight, taking into account her activity level, her fitness goals, or the presence of acute or chronic illness. So for a woman 50 and over weighing 180 pounds, this equates to 80 to 120 grams of protein per day. Many of my patients are interested in healthy weight loss strategies due to a collection of cardiovascular risks and an elevated BMI that places them into the overweight or obese category. So I'm typically following the Joslin Clinical Nutrition Guidelines for protein recommendation in these cases, which recommends 1 to 1.5 grams of protein based on an adjusted body weight. Joslin Clinical Nutrition Guidelines for prediabetes, for people with who have overweight or obesity, also provide nutrition guidelines based on caloric intake. And then for athletic women who train, and I consider any woman, exercising beyond 300 minutes per week or who are engaged in prolonged or strenuous bouts of activity or who have a goal of building muscle and are working out in addition to using dietary strategies to do this. These women may also need increased protein intake to support these goals and to support their performance and their recovery. So they may be recommended anywhere from 1.4 to 2 grams of protein per kilogram of body weight. So that's a lot of protein. When we go through the dietary intake and determine current protein intake, and then we're individualizing their optimal protein intake or goals, sometimes it's quite a jump. I'm typically trying to support women in finding ways to increase some dietary protein. So I do provide handouts and resources to help them meet these protein goals because getting 25 to 30 grams of protein at a meal can be challenging. And I'm encouraging choosing plant-based protein as well as lean animal-based sources if those are included in the dietary pattern. And we now also have really helpful AI tools to assist with meal planning, as well as referrals to dietitians and nutritionists who can personalize this as well. And this is an example of a part of a handout that I share with patients. So I've been counseling women long enough to have experienced the shifting tides of messaging regarding protein intake as well as fat intake and carbohydrate intake. Earlier in my career, I spent a lot of time counseling on why it was not necessary to fear dietary fat. And now we have more confusion about the specific types of fat to include. But dietary fat is important in a healthy diet. And healthy fat can include both saturated and unsaturated fats found in whole foods, but the balance here matters. So fat helps to slow gastric emptying, so it is very helpful in promoting a sense of fullness. It also assists in the absorption of those very important fat-soluble vitamins, A, D, E, and K. And then every person's going to have individual needs, including which dietary fats to include in their diet. I prioritize the inclusion of polyunsaturated and monounsaturated fats in the diet, and we review where to find these types of fat in food sources. And I discuss including both full fat and low fat dairy in the diet based on the individual in front of me. So saturated fats found in full fat dairy have shown a neutral to modestly beneficial association with cardiovascular disease risk. That's similar for both milk and yogurt, but sometimes we are focusing on ways to reduce caloric intake. So choosing low-fat options makes better sense. And for women with elevated LDL cholesterol and increased cardiovascular risk factors, I'm recommending choosing lower saturated fat options due to consistent and replicable data showing that replacing saturated fat with polyunsaturated fats reduces cardiovascular events and helps with LDL lowering. But I am very much promoting the regular inclusion of whole nuts and seeds and trying to find ways to get people to include about a quarter cup of nuts in their daily diet. I spend time differentiating between quick carbs and fiber-rich carbohydrates and why the different types of carbohydrates influence energy and metabolism. And this is where food label reading comes in as a really important lifestyle habit. And most of us are eating food that does come in a bag, box, or container of some kind. And few people are interacting with the nutrition facts that come with that information. So we actually have really helpful information at our hands to help guide our dietary habits, but we do need to develop the skill on how to navigate a food label. So starting with the ingredient list helps to understand what exactly you are eating or drinking. And of course, the order of the ingredient list matters. The first ingredients indicate the most the ones that are in the highest concentration. So I apologize for the tiny font size here, but I often use yogurt in containers as a great starting point for interacting with food labels. And when you start with the ingredient list first, the label on the right shows a single ingredient. It says cultured non-fat milk. Whereas the ingredient list on the left shows several ingredients, including many sources of added sweeteners. So we've got, so the second ingredient, of course, is cane sugar. So we can guess that the product on the left is going to have more added sugar in it. And certainly it does. When we continue to read the food label, we find out that there are 11 grams of added sugar in yogurt on the left, compared to 0 grams of added sugar on the yogurt on the right. So again, starting to use common foods or ingredients and getting a little bit of interaction with those labels can be helpful. And I think that the FAME series does an excellent job of teaching participants over several weeks how to navigate a food label. So including pay attention to the serving size and servings per container, as well as training the eye to go through and look for not only the amount of added sugars, but how much fiber is contained in that food or beverage, as well as protein. The American Heart Association provides some guidelines about the amount of added sugar to limit daily for women's health. And this is about 24 grams per day or 6 teaspoons per day. This is easy to go over. And to put this into perspective, just drinking a 12-ounce soda has about 36 grams of added sugar. Many small containers of sweetened yogurt contain 16 grams of added sugar. So again, this is an important reference for women who have prediabetes diagnosis or any woman looking to support balanced blood sugar. Most Americans are eating only half their recommended amount of daily fiber. So in general, women should aim for about 25 to 30 grams of fiber a day, sometimes more than that. And this includes sources of both soluble and insoluble. And most plant foods contain both. sources of fiber. But again, why are we focusing on fiber? How can we help motivate a fiber-based diet? Well, fiber helps feed the gut microbiome, that friendly bacteria, which then supports a healthy metabolism. And it helps the body process cholesterol by binding to the cholesterol containing bile acids and moving them out of the body. So psyllium husk fiber in particular has been shown to lower LDL cholesterol by up to 15 milligrams per deciliter when consumed at 8 to 10 grams a day in divided amounts. And I do talk about this supplement in particular with patients when we may be aiming for some LDL lowering, because if you've ever mixed psyllium husk and water, it can be an interesting supplement to take. It also comes in capsules. I also provide a fiber handout in the clinic, and my patients can quickly find foods that they already love, that are fiber rich, like avocados that contain 12 grams of fiber in a medium avocado, or half a cup of beans typically has around 7 to 9 grams of fiber. And the beautiful thing about promoting fiber in the daily diet is that it leads to a greater intake of colorful plants, which are where we find rich sources of those antioxidants, and polyphenols, which are those plant-based chemicals. So dietary antioxidants play a role in reducing chronic inflammation, and polyphenols help to support that healthy microbiome and therefore metabolism. Nutrition counseling for cardiovascular health and certainly any concerns with blood pressure should include discussion on understanding a balanced intake of sodium and potassium. And sodium promotes fluid retention and can contribute to vascular stiffness, while potassium promotes vasodilation and counteracts the effects of sodium. But they work best in balance. And again, a low processed and fiber dense dietary pattern often helps to find this balance. But for women who are eating out frequently or regularly consuming pre-made or processed foods, they are at a higher risk of excessive dietary sodium and a lower intake of potassium-rich foods. All right, so this left column is from the nutrition information page from a popular fast food restaurant regarding their breakfast menu. And you can see this is milligrams of sodium that are contained in various breakfast items. And it's quick to see that, these singular breakfast items are quite high in sodium. These are all often breakfast sandwiches. And this is just for breakfast, right? So sometimes getting upwards of 1,800 milligrams of sodium with breakfast really increases that risk of going over 2,300 milligrams per day. And again, for folks who were paying attention to blood pressure, this is something we want to watch out for. Now, I also have a lot of women who are adding electrolyte powder to their water to help them with their water intake, but they're not reading the label, and they're not seeing just how much sodium is contained sometimes in these packets, which can be up to 1,000 milligrams of sodium. So just a caution for water flavoring options that sometimes those electrolyte powders can be very high in sodium. I've included resources about dietary sources of potassium for you to review. And again, women with kidney disease may need to be particularly counseled on moderating their potassium intake, but resources are helpful in figuring out, 5 foods that a woman actually enjoys eating or is interested in eating that are high potassium is helpful. And again, I promote the Mighty Avocado, which not only fiber rich, but potassium dense as well, with over 500 milligrams sometimes per serving. All right, we just published, my co-author, Dr. Julie Briley, and I, the second edition of the Food is Medicine Everyday book, which is used as an academic resource as well as a nutrition guide for the FAME series. And this book provides a solid foundation in understanding nutrition, as well as over 50 delicious recipes I'm not a chef or any specialty training, but these recipes are doable and yummy, many of which are prepared and enjoyed in a community setting during the FAME classes. So there are 15 chapters. They include a review of protein, fat, and carbohydrates, as well as how to review food labels, strategies for healthy digestion, how to build a healthy FAME plate, exploring sweeteners, benefits of breakfast, healthy eating on the go, healthy nutrition, lunches and snacks, a basic shopping guide, and a review of basic kitchen skills. So I've actually shared a couple of my favorite recipes, beans and rice bowl with some added protein in it, and then baked kale chips, which is a very regular occurrence in my household. Physical activity is a modifiable risk factor for cardiovascular disease. And for many women, I'm actually promoting the mental health benefits as the initial and primary benefit. But it is helpful to have some parameters on prescribing movement and exercise. So movement of any kind matters. And for some women, this means first focusing on their NEAT movement, which is their non-exercise activity thermogenesis. These are basic activities that they're already doing. And then also breaking up extended periods of sitting is important for those of us who sit behind a desk at work. I've shared a few prescriptions for exercise, but I do want to point out that the weight loss maintenance recommendations, visiting the National Weight Loss Registry is a helpful resource, and you'll see that 90% of the registrants who were successful in maintaining weight loss, which is really a challenge, were exercising 60 to 70 minutes a day. And so I do share this as a tool for depending on where folks are in their weight loss journey. And now for any of my patients who are deconditioned or frail or have an orthopedic injury, I will often recommend or will consider referring them to physical therapy, especially if I'm recommending that they increase their resistance training so that they can address both their orthopedic and their metabolic health goals that include a recommendation of resistance training. And then don't forget to remind women that small steps matter. Just 10 minutes, even 5 minutes of walking after meals can improve glycemic control. Ask women about their sleep. Insomnia is common, affecting up to 30% of women. And we know chronically poor sleep can negatively impact metabolic health because it contributes to hormone dysregulation, including decreased leptin, which impacts fullness and satiety, increased ghrelin, the always hungry, never satisfied hormone. This can happen even after one night of poor sleep. Chronically poor sleep is also a risk for dyslipidemia and hypertension and increased inflammation. So I ask a lot of questions about sleep disturbances. We review medications and substances that can interfere with restorative sleep. So I'm definitely asking about caffeine and alcohol intake. When is that last cup of coffee? A lot of people are, last cup of coffee 2, 3 in the afternoon, but caffeine can affect people up to 10 to 12 hours. And while alcohol can be sedating, it can definitely lead to disrupted sleep and commonly night sweats. SSRIs, pain medication, corticosteroids can also negatively impact sleep in some cases. I consider blood sugar dysregulation, both hypo and hyperglycemia, which can occur from eating too late, eating an unbalanced meal at night that's too rich in high glycemic foods and not enough of that protein, fat, fiber focus, not eating enough protein for dinner, skipping meals. So blood sugar dysregulation can disrupt sleep, but also can contribute to night sweats. And then, of course, consider sleep disorders like obstructive sleep apnea, shift work, sleep disorders, or restless leg syndrome. And if you suspect sleep apnea, if there's a history of snoring or other risk factors, please refer for a sleep study. Menopausal symptoms, including night sweats, can, of course, be highly disruptive and also many women aren't connecting disruptions from their partner, child, or pet. Here's a sleep hygiene um, for you to review. And then we know significant acute and chronic stress affects the hypothalamic pituitary adrenal axis, and it can make it very difficult to manage blood sugar and healthy blood pressure due to the wide-reaching effects of cortisol and adrenaline. So I review symptoms of stress overload, which can include things like brain fog and sleep struggles, many things that might feel familiar to people listening today, low energy, desire for increased alcohol or sugar. And then the good news is that we have a variety of tools to support increased stress tolerance at the individual level. And women do not have to add all of these strategies to their to-do list. But choose one, choose a couple. But these recommendations do play a valuable role in improving the HPA axis function and that stress tolerance, especially sleep hygiene. Having access to positive relationships, reducing a sense of isolation, treating underlying depression and anxiety. And many women don't know the positive benefits to their nervous system from mindful breathing practices. And resources for this can quickly be shared, and I'll often do very basic, like 4 square breathing or some diaphragmatic breaths in the office with women just to help promote or start that practice. And then as a naturopathic doctor, I will also, in some cases, consider the role of adaptogenic herbal therapy. Some of these herbs, maybe ashwagandha, rhodiola, maca, and holy basil. So addressing stress overload and increasing stress tolerance for women brings me back to the beginning of my talk. So, women are known for making the majority of the healthcare decisions in their family. So, beyond empowering a woman on an individual level, where clinicians can serve an important role to reduce the overall burden of chronic stress and therefore heart disease, will require an approach that is multi level and team based as well as interventions that improve income, environment, healthcare, and education. So we definitely have some work to do. All right. That is actually the end of my talk. So we may have some time for questions.
Wonderful. Thank you so much, Dr. Jackson, for such an informative talk. We have a few questions in the chat. So I'm going to ask the first one. How important is the consumption of organic food?
Sure. I think organic food is, you know, there's certified organic food, and that basically indicates that certain chemicals and antibiotics were not used in the production of those foods. But the nutrient density is going to be, I think, the primary focus here. I do support, when people have access to and can afford organic food, um, that can be helpful for reducing exposure to certain chemicals and pesticides. But the nutrient density will be, I do try and encourage that as a primary focus. So including fresh fruits and vegetables. And there are some resources that are available to help people navigate if they're interested in learning which foods have higher pesticide or herbicide exposure. The Environmental Working Group maintains a list. So sometimes it's helpful to go over that where people can learn what are the most heavily exposed fresh fruits and vegetables, and they can be more picky choosy about which fruits or vegetables they may choose to purchase organic.
Wonderful. We also have a few questions related to other types of diets that are not Mediterranean, like keto or paleo. And, what is your take on those?
Yeah, so that's such a great question. I'm typically not I'm not well versed in the ketogenic diet, and it's said it it's not, it is quite a restrictive diet in terms of the variety of nutrients that it includes. So probably not a great person to discuss that one. But I do try and stay aware of different dietary patterns like the paleo model, because sometimes it's helpful to understand what a patient is interested in, as long as the dietary pattern is inclusive of those major macronutrients, protein, fat, and fiber-rich foods. I'm open-minded to considering it. And again, sometimes it's just helpful to recommend a dietary pattern that comes with resources. So the Mediterranean diet and paleo diet, DASH diet, these are helpful for patients because they can access recipes or other supportive ways to implement the dietary recommendations. Um, but again, I am trying to find and look for the well-roundedness of the dietary pattern.
Wonderful. There are some questions about protein shakes. So what do you think of those? Drinking them for lunch, or protein
Yeah.
bars, are they a good source of protein?
Yeah, so yes, they do provide protein. Protein powders and protein bars do provide protein. Um, And also, they can actually be a very valuable tool to help supplement. These are supplements. So they help supplement a hopefully diet based around food. But yes, they can be helpful supplements to support an overall dietary pattern. This is where food label reading, though, really becomes helpful. And as with any supplement or any packaged processed food, I do encourage reading that food label and seeing what other ingredients may be traveling with the protein powder, and watching out for, additional sources of added sweeteners or added sugar that you may not be aware of. So I do definitely discuss the role of protein powders as helping to supplement and meet some of those needs. But when we can, focus on foods first, and making sure that there's a balance there.
Wonderful. And then I think we have time for one more. What level of intensity are you working? If you're working out 60 to 70 minutes a day, would you recommend?
Oh, that's a great question. So the 60 to 70, it's typically going to be, again, I'm not an exercise physiologist, but I'm encouraging at that level that you're still able to talk and hold a conversation. Once we're moving into more, that's moderate, a moderate level of exercise. You're breathing hard, but you're able to converse. Once we're moving into that vigorous exercise of which you can accomplish your cardiovascular goals with less minutes, with a more vigorous exercise. That's intensive exercise. That's often harder to engage in a conversation. And sometimes that model works better for people who are interested in being more efficient. But the 60 minutes you're conversing, and I would consider that more of a moderate engagement.
Wonderful. And research shows also like a high interval training, which consists of those intervals and then periods of rest, uh, shows some benefit to both cardiovascular health, sleep, stress tolerance, and so many other things. And we're definitely going to have some talks addressing more nuances related to healthy lifestyle. But you've covered so many different aspects of lifestyle medicine that can be helpful to anyone. And I think we
Great.
are at time. So thank you everyone who joined us for the lunch time. I hope you combine, cognitive information with something good, nutritious for your lunch. We also are gonna send the presentation and recording to everyone who attended. So don't worry, you'll get all this context for your reference. And with that, thank you so much, Dr. Jackson. Thank you, everyone. Have a wonderful day.
All right. Thank you. Bye-bye.
Bye.